Herniation of a cervical intervertebral disc. The cervical spine is subjected to stresses that result from disc degeneration, from aging, occupational stresses, and spondylosis, degenerative changes occurring in disc and adjacent vertebral bodies. Cervical disc degeneration may lead to lesions that can cause damage to the spinal cord and its roots. A cervical disc herniation usually occurs at the C5, C6 and C6-7 interspaces. Pain and stiffness may occur in the neck, the top of the shoulders and the region of the scapula. Sometimes patients interpret these signs and symptoms as of heart trouble or bursitis. Pain may also occur in the upper extremities and head, accompanied by paresthesia, that is tingling or a pins and needles sensation, and numbness of the upper extremities. Cervical MRI usually confirms the diagnosis. Medical management. The goals of treatment: one is rest and immobilize the cervical spine to give the soft tissues time to heal. Number 2, to reduce inflammation in the supporting tissues and the affected nerve roots in the cervical spine. Bed rest, usually 1 to 2 days, is important because it eliminates the stress of gravity and relieves the cervical spine from the need to support the head. It also reduces inflammation and edema in soft tissues around the disc, relieving pressure on the nerve roots. Proper positioning on a firm mattress may bring dramatic relief from pain. The cervical spine may be rested and immobilized by a cervical collar, cervical traction, or a brace. A collar allows maximal opening of the intervertebral foramina and holds the head in a neutral or slightly flexed position. The patient may have to wear the collar 24 hours a day during the acute phase. The skin under the collar is inspected for irritation. When the patient is free of pain, cervical isometric exercises are started to strengthen the neck muscles. Cervical traction is accomplished by means of a head halter attached to a pulley and weight. It increases vertebral separation and thus relieves pressure on the nerve roots. The head of the bed is elevated to provide counteraction. If the skin becomes irritated, the halter can be padded. Experience has shown that male patient may suffer more skin irritation if he shaves. The bed offers a natural form of padding. Pharmacologic therapy: analgesic agents, NSAIDs, that is non-steroidal anti-inflammatory drugs, prescribed during the acute phase to relieve pain, and sedatives may be administered to control the anxiety often associated with cervical disc disease. Muscle relaxants are administered to interrupt the cycle of muscle spasm and to promote comfort. NSAIDs, aspirin and ibuprofen, or corticosteroids are prescribed to treat the inflammatory response that usually occurs in the supporting tissues affected nerve roots. Occasionally, an injection of the corticosteroid into the epidural space may be administered for relief of radical or spinal nerve root pain. NSAIDs are given with food and antacids to prevent gastrointestinal irritation. Hot, moist compress for 10 to 20 minutes applied to the back of the neck several times a day increase blood flow to the muscles and help relax the spastic muscles and the patient. Surgical management: surgical excision of the herniated disc may be necessary when there is significant neurologic deficit. Progression of the deficit, evidence of cord compression or pain that either worsens or fails to improve. So surgical excision is needed when there is significant neurologic deficit, progression of deficit, evidence of cord compression, pain that either worsens or fails to improve. A cervical discectomy with or without fusion may be performed to alleviate symptoms. An anterior surgical approach may be used through a transverse incision to remove disc material that has herniated into the spinal canal and foramina. Or a posterior approach may be used as the appropriate level of the cervical spine. Microsurgery such as endoscopic microdiscectomy may be performed in selected patients through a small incision and using magnification techniques. The patient who undergoes microsurgery usually has less tissue trauma and pain and consequently a shorter hospital stay than after conventional surgical approaches. The potential complications with the anterior approach include carotid and vertebral artery injury, recurrent laryngeal nerve dysfunction, esophageal perforation, and airway obstruction. Complications of the posterior approach include damage to the nerve root or the spinal cord due to retraction or contusion of either of these structures, resulting in weakness of muscles supplied by nerve root or cord. Nursing interventions, it include relieving pain, improving mobility, monitoring and managing potential complications, and teaching patients self-care. Thank you.